Welcome everyone to today's webinar, Adolescents and Young People, High Impact Practices. My name is Nandita Tate and I will be the moderator for today's webinar. This webinar is hosted jointly by the IBP Initiative, the High Impact Practices Working Group, and FP 2020. Next. The format for the webinar will be as follows. We will start with an introduction. I will provide an overview of the HIPs. We will then hear from two of our presenters on some technical content related to the topic. And then we will hear from one of our panelists on some comments and reflections on the presentations. Time permitting, we will allow for some questions before closing the webinar in about 1 hour. Before we begin, next slide, I just want to flag a few things for our participants dialing in. One, in your lower right-hand side of your screen, you will see a tab that lists handouts, and there you will find various handouts related to the high impact practices. You will also see a little tab for questions. So please do submit your questions throughout the presentations, and time permitting, we will do a small Q&A at the end. The webinar will be recorded and will be posted on the High Impact Practices website, which you can see listed on your screen. Again, welcome to everyone joining from around the world. We had over 200 people registered and about half of you have joined, so welcome again. As I mentioned, I will start by providing a short overview of the high impact practices and the IBP initiative. For those of you who are not familiar, the IBP initiative is a WHO housed network of NGO and civil society partners with a mission to support the dissemination and use of evidence-based practices in family planning and reproductive health. We have 3 strategic objectives, you can see them listed there, around increasing access to evidence-based tools and guidelines, supporting implementation, and facilitating partnership. And it's an important point to stress because in addition to promoting WHO guidelines, research results, and tools, we also focus many of our efforts on the high-impact programmatic practices in family planning. Next slide. So what are the high impact practices in family planning? Many of you are probably already familiar with these. You can find more information on the website, where you will also be able to find a more detailed webinar outlining the process of developing the HIPs in a little bit more detail. But overall, the high impact practices are a set of evidence-based programmatic interventions. They have been informed by a technical advisory group. This is a group of around 25 international experts in family planning research, program implementation, donors, and others. They meet once a year, and the purpose is really to review the evidence on various interventions in family planning. Criteria for inclusion as a HIP really center around demonstrated impact on contraceptive use and relevancy in a variety of country contexts, given the variety of countries and the diversity in which we work. However, we know that country context is important, and so consideration is also given to issues around replicability, scalability, sustainability, and cost effectiveness. The image on your screen is the 2-page HIP list, and this list in a succinct way defines what we mean by a HIP, and it provides a list of the various high impact interventions. We do have evidence briefs for many of the interventions, and I will discuss those in a moment. You should note that all of the HIP materials are translated into 4 languages. And just to note that the HIP work, like much of the work that we do, is a process that is constantly evolving and is really built on partnerships and collaboration. Next slide. There are a number of different HIP products to help inform family planning programming related to youth and population in general. These include evidence briefs, evidence summaries, HIP enhancements, and strategic planning guides. And I will discuss some of these in a moment. Evidence briefs are really programmatic interventions that have been organized thematically around service delivery, social behavior change, and enabling environment. The evidence summaries are compilations of evidence around various topics around which we might not have a robust amount of evidence or cannot be categorized as a particular intervention. So for example, we have an evidence summary developed around economic empowerment as a potential way for women and girls to gain control over their sexual and reproductive health. HIP enhancements are meant to help strengthen the implementation of various HIPs. And I will talk more about these in a minute when it comes to programming for young people. And finally, strategic planning guides are documents that can help program managers and policymakers identify and prioritize the various high impact practices. Next slide. As I mentioned, the HIPs are organized in 3 categories, thematic categories: service delivery, enabling environment, and social behavior change. When thinking about HIPs for adolescents, it's important to note that the high impact practices are interventions that can be applied across population groups. However, we know that the evidence is stronger around some interventions when programming for young people. For example, we know that drug shops and pharmacies are preferred by some marginalized or underserved populations, including youth. I should also stress here that the service delivery HIPs have been organized based on the strength of their evidence. So there are some HIPs that are proven and others that are promising. Next slide. As mentioned, the HIPs are really just interventions. And when talking about adolescents, we're really talking about a population group. And so the HIP enhancement can help us strengthen implementation of the different service delivery interventions for this particular population. So the idea here is to use the enhancement as a way to intensify the impact of the various HIPs, specifically when working for adolescents. This HIP enhancement describes how mainstreaming adolescent-friendly contraceptive services can address key challenges for contraceptive programs. It discusses the existing evidence of adolescent-friendly elements, outlines key issues for planning and implementation, and also helps to identify knowledge gaps. Next slide. When it comes to the enabling environment, again, there are several HIPs in this category. One in particular that is relevant when programming for young people is the evidence-based practice around educating girls. And this document really helps provide recommendations for how the health sector can help support keeping girls in schools. Next. The final category of HIPs are around social and behavior change. And again, many of these can be applied across populations. When it comes to adolescents, the same is true, though we know that there are some that may be more relevant when programming for adolescents. For example, given the high use of digital technologies among young people, we see that the HIP for digital health for SBC may be of particular relevance when programming for adolescents. Next. And finally, we have a strategic planning guide focused for adolescents. And again, the purpose of this document is to provide strategic guidance to help identify and prioritize interventions when programming for young people. It outlines several key considerations to consider when developing a program, and you can see those listed on the right. 1, know your adolescents, understanding the drivers of adolescent pregnancy, how to create an enabling environment, reaching young people with information and with contraceptive services, and how to reduce financial barriers to contraceptive services. Next. So what I've provided until now is a really brief overview of the HIPs and some of the HIPs relevant when thinking about programming for youth and adolescents. What I'd like to do now is just highlight a few activities that we've done through IBP to help promote HIPs to support adolescent programming. Dissemination is a big part of our strategy through webinars, partner meetings. We recently partnered with the PMNCH Partners Forum in India to have a youth-led knowledge bazaar where the hips were featured prominently as part of this event. We are also involved in helping to support implementation and scale up and measuring these efforts. And what has been interesting is a recent IBP member survey found that the Adolescent Strategic Planning Guide was one of the most widely used products promoted by IBP. We have been involved in some work around documentation, particularly around adolescent-friendly services. And then finally, one advantage of promoting the HIPS through IBP is our ability to link the high impact practice work with WHO guidelines and other UN resources. So we have been able to help promote and make linkages between the HIPS and WHO guidelines like the AHA framework and the recently published WHO recommendations on adolescent sexual and reproductive health and rights. So with that, I will turn it over to our first presenter. Again, just welcoming today's panelists. I'm Michelle Weinberger from Avenir Health, Arwani Masusia from the College of Medicine Malawi, and Amy Uccello from PSI. Welcome to all of you. I'd like to introduce our first panelist. Next slide. Michelle Weinberger. Michelle is a demographer with a focus on family planning and reproductive health, and she currently works as a senior associate with Avenir Health, where she provides technical support to Track 20, conducts analysis, and develops models related to reproductive health. Michelle, I'll turn it over to you.
Great, thank you. I should also say that I am a member of the HIP tag group, and so excited to be here, both with my kind of Track 20 data hat on and also with that experience working on the HIPs. So today I'm gonna share a little bit of analysis done through our Track 20 project to talk about what we can learn from the data when looking at adolescents. Next slide. So a lot of times we hear that we just don't have data on adolescents. There's sort of this feeling that there's a dearth of information on what we know. But I actually think we have quite a lot. Of course, there are gaps and there are more things we could know, but between both surveys and routine data, both of which we'll look at today, there's actually quite a bit of information that we can get to really understand what's happening in different countries with this group of adolescents. I know today's webinar is focused on sort of more broadly youth and adolescents. Today, we're mostly gonna focus on that 15 to 19-year-old group that we talk about as adolescents. We're gonna draw a lot from survey data, primarily demographic health surveys. A lot of what I'm gonna be showing you guys today is stuff that isn't necessarily in the published reports, but if that you go back into those survey data sets, there's a lot more that you can pull out to look more at that 15 to 19-year-old group. And then at the end, we'll come back and look at a couple examples from routine data. So this is stuff coming from countries' health management information systems, such as DHIS2, that in many countries, we see a lot of age disaggregation within those systems. So letting us look at sort of what's happening in that younger age population. Next. So it's important to think about what we want to get from our data, right? Data can tell us lots of different things and answer lots of different kinds of questions. And so here, I'm going to frame today around 3 types of things we can use our data for. So first is context. Data can help us understand patterns and trends, how things differ both across country and within country, kind of doing that stage setting to understand what the needs are. Next is opportunities. We can use the data to think about where needs are greatest and therefore help in thinking about prioritization of efforts. So we know that we can't do everything. And so how can we use data to tell us what things might be most impactful or might reach the most number of adolescents in different countries? And then finally, monitoring, so that as we're implementing our HIPs and doing our programming, we can use data to see if we're having the effects that we wanted to have. And of course, across all these different needs, the questions that we want to ask our data are going to be different. And so today we're just going to pick a couple of examples to talk through. Next. So as we heard from Nandita just before, we have a range of HIPs that touch on issues of adolescence, and then we have even more HIPs that might not be adolescent or youth specific, but still relate to how we might think about reaching young people. But generally, I think we can kind of divide them thinking about it two different ways. So first, we have things that directly relate to contraceptive services. And so when thinking about our adolescent population, this is really going to be more narrowly focused on married and unmarried sexually active adolescents who want to avoid a pregnancy. Those are the ones who really need those direct contraceptive services. And then we have HIPs and interventions that address kind of social norms and enabling environments, more on the demand side. And for that, we're going to look more broadly because we might have adolescents who don't have a current need for contraception, but who can still be reached for these programs. So either through education, through addressing norms, through creating future healthy behaviors. And so one thing we'll look at today is how can we use data to understand in what context which of these focuses might be most important or where we might need a real balance between them, because we have a lot of young people and adolescents falling into both of those different groups. Next. All right, so jumping into the data. So what this slide shows us is data from surveys across countries looking at the timing of 3 key life events: the age of first marriage, the age at first sex, and the age at first birth. So this graph shows us the medians, so sort of the average experience of young women across these countries. And what we find is that generally we see 2 different patterns. So the group of countries on the left have a pattern where first sex happens after first marriage. Often that timing is close together, but that generally the marriage is happening first, then sex within that marriage, and then finally their first birth. On the right-hand side of the slide, we see our other pattern, which is where the first sex happens before marriage, though we see a lot of diversity in the timing of that. So in a country like Mali or Burkina Faso, those 2 are happening pretty close together. Or in a country like Ghana or Haiti, we see quite a large gap, a couple years between the median time when young women are first having sex and when they're first getting married. And so we can think about how, depending on the timing of these events, the needs of adolescents are going to look quite different, because you're going to have adolescents who are largely not sexually active. You're going to have maybe more levels of sexual activity outside of marriage. So that's going to have very different needs for contraceptive services and reproductive health, versus young women who are getting married early and having their first children, that their reproductive health needs are going to look quite different as well. And so we can think about how this data can help us start to think about differences across countries and therefore what type of programming might be most effective. One thing I want to point out, and you'll see this is a continued theme throughout all of these slides, is just how much diversity we see across countries. So even countries that might sit in the same region that we might think of as having a lot of similarities, we see quite different patterns. And so it's really important when we think about adolescence and programming that we really make sure we're right sizing to each country's individual and unique context. Next. So another way to think about context is to think about the levels of contraceptive use, or modern contraceptive prevalence, MCPR, among unmarried sexually active versus married adolescents. And so what this graph shows us is the relationship between these 2 different indicators in each country. Each dot in this graph represents a DHS survey from a country, their most recent data point. And I've picked out a couple examples just to talk us through some different patterns that we see. So in this graph, the further up a country sits, then the higher the level of contraceptive use among unmarried sexually active adolescents. The further to the right a country sits, the higher the contraceptive use among married adolescents. Countries that sit above that yellow dotted line, so those are the blue countries, the level of contraceptive use among unmarried adolescents is higher than married, and those purple countries sitting below the line, the opposite is true. So they have a higher prevalence among married women than unmarried women. So one thing we see is that in most countries, the majority of the pattern that we see is higher levels among unmarried than married. And that kind of makes sense because we know that that unmarried group generally has a much higher need or desire to avoid pregnancy. And so we see generally already that they are kind of using contraception at higher levels than their married counterparts. But of course, again, we see a lot of diversity. So for example, if we look at Nigeria, Nigeria has pretty high contraceptive use among unmarried adolescents. It's at about 50%, but it's almost non-existent among married women. It's only about 1%. So you have this huge difference between their level of contraceptive use in these 2 different adolescent populations. In Madagascar, down towards the bottom there, we see fairly low use in both groups. So about 17% among unmarried and 14% among married. So in that case, we have low use among both groups. Moving to Zimbabwe, we again have pretty similar levels of use between those two groups, but those levels are higher at a more kind of moderate level. So at 45 and 40%. And then finally moving to Colombia, where we see unmarried and married use are both very high. So 76% of unmarried sexually active adolescents are using contraception, and 61% of married adolescents are using contraception. And of course, in between these four examples, we see countries sort of falling all over in different places. So one thing this graph doesn't tell us about is the size of these different groups. So this tells us within the group of married adolescents or within the group of unmarried sexually active adolescents, what share of them are using contraception, which is important. But we know that in countries, the size of these groups varies very drastically. And so it's important not to just think about what's happening within the groups, but think about how big those groups are. Next. And this is where we really kind of bring together our context and our opportunities. And so going back to this graph we saw before, we're now going to look at a couple country examples, so the ones in green boxes there from these two different patterns. And we're going to bring together this information that we looked at earlier about the timing of these different life events, which is going to tell us about how many adolescents fall into different groups of being married or unmarried or sexually active or not sexually active. And we're going to overlay that with the data we saw on the last slide about contraceptive use and bringing in some information about unmet need to think about the size of different segments of adolescents in different countries. Next. All right. So bringing all this information together, we see in this graph in front of us the distribution of all adolescent girls aged 15 to 19 in each country. So first, we've segmented them by whether or not they have a need for contraception. So everything in the gray are adolescents who don't have a need. Everything in the green are adolescents who have an unmet need. And everything in the blue are adolescents who are already using modern contraception. Each of those groups is then subdivided to look at marital status and sexual activity. So we can think about how that need or no need or use varies across these different groups. So I'm going to talk through this graph starting at the top and going down. So that light gray segment are adolescents who are unmarried and not sexually active. For the purposes of this analysis, we've looked at adolescents who haven't had sex in the last year. So we didn't look at ones who have never had sex. Also, a lot of times analysis only looks at whether or not an adolescent has had sex in the last 30 days. But at Track 20, we've decided the 1 year is a good marker to look at adolescents who do or do not have sort of a current potential need for RH and contraceptive services. So what we see is that with the exception of Niger, that the majority, more than half of all adolescents in these other countries fall into that group of having no need because they're unmarried and not sexually active. In India and Myanmar, this makes up the vast majority, 85 and 87% of adolescents. For these adolescents, there might be important interventions that can help prepare them for when they start having sex or when they become more regularly sexually active again in addressing their future reproductive health needs. And so a lot of those enabling environment HIPs and SBC HIPs that Nandita talked about might be useful for this population. So to think about how we prepare them to have healthy behaviors in the future. We also see fairly large segments, though the size of them varies across countries, of married adolescents who don't have a need. We see that in the dark gray. This group is largest in Niger, where the age of marriage is quite early, so a lot of our adolescents in that country are married rather than unmarried, as we see in some of the other countries. So these are young women who are either already pregnant with a pregnancy that they wanted or trying to get pregnant. So for this group, there's SBC interventions that could help look at issues around both age of marriage, as well as issues around norms of childbearing and fertility within marriage. So things that promote healthy birth spacing, that promote delaying first births within marriage till a healthy age, all of those types of interventions. So these young adolescents don't have a current need for contraceptive services, but there are interventions that might help reach this group. And then finally, in the green, we have our segments with unmet need. So what we see is that the segment varies in size across different countries, And we also see variation in terms of whether this unmet need is concentrated among unmarried adolescents, which is in the light green color, or whether it's concentrated among married adolescents, which is in the dark green color. So for example, in Niger, India, and Myanmar, we see that that unmet need is really concentrated in married adolescents, with very little or no unmet need among unmarried adolescents, mostly because these countries have so little sexual activity outside of marriage. In countries like Burkina and Nigeria, we see a pretty even split between the level of unmet need among both married and unmarried adolescents in absolute terms, so sort of make up a similar number of adolescents in those countries. And then in Uganda and DRC, we see that unmet need is much more concentrated among the unmarried sexually active group. And we can think about how, depending on the size of these different segments in different countries, our programming needs would need to look very different in order to make sure that they're addressing the needs of these different adolescents. Next. So in the last slide, we looked at the share of all adolescents who fall into each group. In this slide, we're looking at that same data, but here we're considering how that relates to all women of reproductive age in a country. Because if we want to think about the national impact that reaching adolescence could have, it's important to not just look at what's happening among adolescents, but looking at what that means in terms of that wider group of women of reproductive age. And what we see are some differences in the last graph compared to the last graph, because we have different age structures in different countries. So in a country where a lot more of the population, a larger share, falls into that adolescent group, they're going to have a larger share within this graph. Whereas in a country where the age structure is such that we have a smaller share of women of reproductive age who are adolescents, a smaller share might fall into the group that has unmet need when looking at that wider picture. And so here, really focusing in on unmet need, we can see that there are some countries where the unmet need among adolescents is relatively small when we compare it to the whole population of women of reproductive age. But we also see some countries, like in Uganda and DR Congo, where collectively that group of adolescents who have an unmet need make up 4 or even 5% of all women of reproductive age. So thinking about those countries having a lot of potential to have a really big impact at the national level in addressing the needs of those adolescents. And while I know that meeting the needs of adolescents is critical, we also need to make sure that we're balancing our efforts so that we're also meeting the unmet needs that exist outside of that adolescent age period, and making sure that within each country, we're really looking at where that adolescent need fits into that wider picture. Next. So now moving on to look just quickly at some data we can use for monitoring. So all of our previous slides have drawn from survey data, whereas here we're looking into routine data. One of the advantages of routine data is that it's recorded down at the most granular level possible, right? So this is recorded at a facility or a clinic and then entered into an HMIS system, which allows visibility either to the district, or in some countries, depending on how their system is designed, you can even access this information all the way down to an individual facility level. So this has a really big advantage in terms of monitoring, because it lets us not only get data in essentially real time, right, on a monthly basis, but also get data at that very low level. So I'm going to look at 2 quick examples here of routine data that can help us think about how we're being effective in reaching adolescents and young people. So the first comes from Tanzania and their HMIS portal. So Tanzania tracks the age of its clients within its HMIS system. And so we can look at trends over time. And so this graph shows us the number of new family planning clients who are under the age of 20 over the course of a year. And what this data could be used for is to think about if we did an intervention at a certain point of time. So say in July 2018, there was a huge effort to do training on adolescent-friendly services, or a large effort to do a mass media campaign. We could monitor to see if we see upticks in these trends that would show that those interventions that we were doing had the impact that we were intending. And if we didn't see those upticks as we were expecting them, that could signal a need to look into more depth to really understand what's going on and see if something needs to be done differently. We also have an example at the bottom from the DRC from a service statistic brief that the Track 20 M&E officer put together there, where they looked at the proportion of facilities within each province that report providing services to young people. And what you see is actually this is quite low across the board. So even in the highest, it's only about 35%, going down all the way to only about 10%. So this might signal that there might be some issues that need to be addressed. We don't know from this data exactly what those issues are, right? We need to look into this more to know whether is this just a reporting issue? Are they not properly reporting the age of their clients? Is it a demand issue? Is it an issue with the service provision? So there's lots that this data can signal to us that we might need to look into more to be able to look at what we can do to really improve the situation and ensure that young people are able to access contraceptive services at all facilities across the country. I want to make one note. We talk a lot about disaggregation and the importance of disaggregating data into young age groups so that we can better understand the needs of youth and adolescents. But we also need to balance that desire for disaggregation with the challenges that creates on a routine data system. So while of course at the facility on the client register, we need to know the exact age of a client in order that those service providers can best meet that young woman's needs. As we start to aggregate that data up and roll it up into our routine system, tracking everything by individual ages or even 5-year age groups can become very burdensome. And so what we would recommend based on looking at different systems and thinking through this is rather than tracking that detailed age, to look at tracking something more aggregated, whether it's if a client is under 20 or over 20, or if the interest in a country is really at a lower age group, maybe moving that down. But trying to do this in a more simple way so that we don't overburden our routine systems and introduce more error and inaccuracy to our data. Next. So I've just thrown a bunch of different data at you guys, but wanted to summarize just a few key messages. First, to say that while of course we know there are limitations in our data, there's actually a lot of data available on adolescents if you know where to look and how to put that data together. Second is that we know that married and unmarried adolescents have very different needs. And as we've seen today, the size of these populations are really different in different countries. And so we need to really think about how do we move from just talking about adolescents in this very singular way to making sure that we're recognizing the unique needs of these different groups. And then finally, as you saw on all of the slides, there's just a huge amount of variation both across countries, as we saw today, but also within countries. So if we did this analysis looking at states within a country or regions within a country, you would see similar variation. And so we must think about how our programs can take into account all of this variation in country context to make sure that they're really focusing on the needs that are most salient in each place. And finally, just to leave you guys with some resources, the hyperlink that you see there goes to Track 20's website, where you'll find lots of information about youth and adolescents, including data within the website that lets you do some cross-country comparisons. And then you'll also have a link to download youth opportunity briefs, which are available for each FP 2020 country. They're currently there in English, they'll soon be there in French, which present a wide range of the data that I talked about today.
Great. Thank you, Michelle. That was an excellent presentation and really showcased how data can help us to better identify and use the HIPs as we move our programming forward. Lots of interesting work there. I'd like to introduce our next presenter, Amy Uccello. Amy has over 19 years of experience working in global health, focusing on adolescent sexual and reproductive health, family planning, HIV, and maternal child health. She's currently the Senior Adolescent and Youth Sexual Reproductive Health Technical Advisor for Population Services International, where she brings health products and services to young people as part of the Youth Power Healthcare approach, working in public-private facilities, the communities, and beyond. Amy, over to you. Thanks.
Thanks, Nandita, and thank you, Michelle. Lots to be learned there. I'm going to take a different approach, and I'm excited to share with you all today our implementer experience bringing to life the high-impact practices with youth voice at PSI. Next slide, please. First, I think we have to ask ourselves, what does a high-impact practice mean to a youth or a girl? Next. We at PSI recognize that the majority of health consumers in the countries in which we work are young. As such, we're pursuing youth-powered healthcare. In that, we know working for young people is not nearly as effective as working alongside them. Youth need to drive their own destinies by taking part in decisions that affect their lives and their communities. This means that we're not only youth-centered, where we're working with the best intentions for young people, but youth-powered, where young people are critical partners in design, implementation, and evaluating the programs aimed at their health and well-being. Next. In this presentation, we've applied the adolescent-friendly contraceptive services HIP to our flagship youth-powered project, Adolescence 360. Next. So youth are not, as we know, a monolithic whole, and as Michelle was just stating, and their behaviors and identities can rapidly shift. That's why girls' questions, concerns, priorities have been driving our programming at every stage. Next. Right now, youth-friendly services are only friendly from an adult's perspective. For too long, young people have been left out of the conversation of what's best for them, even in the provision of their own rights and services. Until we have included youth voice in how we define and deliver their services, then we are making assumptions on how that friendliness is truly defined. When we rebalance power to allow young people to co-design and co-deliver their own services, we gain new perspectives, offer new messaging, and new service options. This allows the HIPs to leap off of the page and become more useful and resonant to young people. In the next few slides, I'll illustrate how bringing young people in allowed us to make the HIP youth-powered. Okay, stay on this slide, please. For example, if we look at the tips for implementation in the HIP brief, the first recommendation is to conduct a needs assessment to identify the most effective approaches to reaching sexually active adolescents with contraceptive services. We hired 260 young designers in A360 who had equal decision-making power, and we saw qualitative data in new ways. One of the more resonant learnings was that girls often do not identify as sexually active. We know research tells us that adolescent sex is often unplanned, infrequent, and forced or coerced in many cases. And girls can move very quickly from not being sexually active to becoming sexually active. One of our more telling insights from girls was, "I'm not having sex, he's having sex with me." Therefore, if we start a needs assessment only with girls who identify as sexually active, we're wholly missing the mark. So what do? We do not ask about sexual behavior as an entry point to counseling or services. It's not part of our messaging. Girls need to see contraception as useful regardless of whether they are sexually active or not. We also know that contraception is often at odds with motherhood, an immediate and attainable dream. So what do? We lead with messaging as a way to protect your fertility when you're ready. And our counseling starts with return to fertility after you conclude with your method, rather than the length of its effectiveness. We offer goal setting and action planning to connect contraceptive use to complementary images girls can see of themselves today. Smart, savvy, prepared to achieve in life, a girl with a plan. This complementary image of themselves can also be possible as well as motherhood. And this girl can be prepared to be a healthy mother when she's ready, and her fertility will remain protected in the meanwhile. Next. The HIP also recommends using multiple service modalities to reach a wider range of adolescents. And while that is true for access reasons such as cost, location, availability, Youth Voice told us that convenience wasn't the only factor of importance. For example, girls in northern Nigeria wanted services at public facilities at regular hours because it legitimized their attendance. Newly married girls in Ethiopia were previously left off the map of their community health workers, as it was assumed by social norm standards that they were to start childbearing right away, being married. But those couples asked for those services at their homes and communities. While Tanzanian girls asked for a variety of service modalities, public, private, peak and off hours, weekdays and weekends. Next slide. The HIP recommends training providers to offer adolescent-friendly services. A big part of what brought about change with our providers was that they were able to interact with young people outside of the training, which generates empathy in a way that merely doing coursework won't do. Young people are hired to work in our facilities, to drive demand to facilities. And in Tanzania, young people came forward to identify positive deviant providers already offering high-quality youth-friendly services, and then they were given an opportunity to receive further training on youth-friendly health services and share their knowledge with other providers. Next. The HIP recommends reinforcing training through supportive supervision, job aids, and mentorship to change provider attitudes and behaviors. But infusing youth voice in how we determine if providers require additional support means ensuring that we have a strong monitoring system. In our case, this has meant meaningfully including young people in our evidence-based adaptive implementation approach. Our staff combined with youth come together to routinely stress test implementation and determine when adaptations are needed. Using mixed methods monitoring, youth interview young beneficiaries and providers as part of routine site supervision, and they highlight areas for increased supervision. In this way, young people are influencing in real time ways to refine services. They are not only beneficiaries, but also problem solvers of their own programs. One example that I can share was an activity that we had piloted in Tanzania to encourage increased traffic at our service delivery events by making announcements at schools. When reviewing our data during the adaptive implementation process, we noticed that the attendance figures were increasing, while the contraceptive adoption rates were decreasing. Upon further inspection by young people, we learned that teachers were telling their students that they should attend our event. However, we learned they were also saying, in order to avoid temptation. In that one moment, all of our youth-powered messaging was lost. We were able to adjust in real time and avoid further negative impact. Next slide. The HIP also recommends enforcing confidentiality and ensuring audio and visual privacy. Although A360 maintains all family planning clinical standards for confidentiality and privacy to all of our clients, regardless of age, we have added additional components to increase visual privacy based on youth voice. According to girls, stigma still remained at service delivery sites, even by fellow young clients. As a result, all girls are offered services in an on-the-spot opt-out moment. In this way, girls are not singled out by walking to a provider after a community event or a community delivery. They don't have to walk down a lonely hallway for all to watch. All girls see the provider to talk about whatever they like. Furthermore, A360 events are highly engaging, keeping girls busy. So no girl is standing around listening to her compatriot or timing the session to determine what kind of method girls are taking up. Next. The HIP recommends that we tailor health communication to the needs and interests of adolescents. Rarely do girls put health first on their list of priorities. Girls in all 3 countries, 4 contexts, urban and rural, married, unmarried, all expressed anxiety about unstable futures and desires for financial and social stability as critical assets to achieving their immediate goals. We listened to girls. We allowed ourselves to think and program outside of the health sector alone. We offer job skills and income generation, financial planning, and social emotional learning first and end with contraception. We have to stop leading with our own objectives or saying that we can't give girls what they want because our funding doesn't work that way. Next. The HIP recommends offering a full range of contraceptive options. Yes, we want girls to have access to all methods regardless of age, marital status, parity, and method of choice. However, youth still tell us there is hesitancy on certain methods based on continued fear. We're trying a new tactic in Nigeria to introduce implants without calling them long-acting methods. All of the clinical factual information is still provided, length of effectiveness and such, but merely not referring to them as long-acting. It's a small adjustment that seems to be making a world of difference as uptake has increased slightly. We will continue to monitor whether its success has caused an impact. Next. Finally, the HIP recommends paying attention to gender and social norms. When girls defined for us their influencers, rather than us making blanket assumptions as we conveniently ran through the socio-ecological framework, we learned a variety of differences. In Ethiopia, girls wanted their husbands present in a combined intervention. In northern Nigeria, girls wanted their husbands to have an intervention as well, but for it to be fully separate from their own. In Tanzania, girls did not feel enough of a connection to their partners to want them around. And in Nigeria, southern Nigeria, girls indicated that they, quote, trusted their partners less than thieves. In this way, safe spaces were very differently defined. The same has held true with girls' connections to their mothers. Next slide. In case you're wondering if any of this has worked for us, here's a quick sample of our results to date. Next. In Kuamajanja, our Tanzania activity, opt-out contraceptive and life coaching services for urban and peri-urban girls, we've seen a 70% adoption rate of contraceptive methods in just over a year. Next slide. In Ethiopia, Smart Start uses financial planning to initiate contraceptive counseling with rural married girls. And we've seen 69% adoption rates of contraceptive methods in just about over a year. In southern Nigeria, Niger Girls uses love, life, and health classes as entry points to inspire and serve urban, peri-urban, unmarried girls. And we're looking at 68% adoption of contraceptive methods in over a year. And in northern Nigeria, also using love, life, and health classes as entry points to inspire and serve rural married girls, 77% have adopted a contraceptive method. So now that we've taken a youth-powered approach to the adolescent-friendly contraceptive services HIP, there's no reason why we couldn't do the same with the other HIPs as well, including those that are listed here. And shame on me for not listing the a360learninghub.org website, but I encourage you to type that into your browser. We'll include it in the lists that will be sent out with the recording so that you can learn more about our project. Thank you so much.
Wonderful. Thank you, Amy. What a great presentation, and really showing us how you at PSI and your teams have used the HIPs to guide and inform your programming, but also made some really important tweaks and small adaptations to really strengthen the impact of the work that you are doing. I'd like to welcome and introduce our final presenter. Warwami Masikia is from the College of Medicine, Social Innovation and Health Initiative in Malawi, where she works on catalyzing local innovative solutions to address healthcare delivery challenges and advance pathways for universal health coverage. Warwani is a true champion for adolescent reproductive health, and in 2016 was a winner of the 120 under 20 New Generation of Family Planning Leaders. Welcome, Warwani, and we turn it over to you on some reflections on the presentations that we've heard today. Thank you.
Thank you so much for having me, and thank you everybody for participating in this webinar. I'll just quickly offer some reflections on what Emily, Michelle, and Emmy shared. I think to begin with, three key questions that we have to ask ourselves is, one, do we know what works? Two, are we doing what works? And three, if we know what works, why aren't we doing it? And also to just step back is, aren't we all tired of sitting on the same tables where you argue about adolescent and reproductive health, but it seems like we go around the same circles? For me, this is why I love HIPS, and I was very excited about this webinar because it represents a pathway and a guide to a resource to stakeholders at different levels. So it could be policymakers looking at redesigning their programs, governments, private sector, but also young people themselves or youth-led organization trying to strengthen the activity that they do. A key thing that I think ties through the presentation and also what Nandita shared is the how that we do things. Because if we reflect back on what Emmy shared and Michelle have shared, yes, the what, the who, and the when matters, but the how they did it is also what is helping facilitate more effective programming around young people. And when we talk about the how, we're looking at how are we designing, but also how do we implement, monitor, and evaluate these programs. So if you remember what Michelle shared, if you look at the slide that for every country, depending on when your adolescents get married or don't get married, from my experience is that in Malawi, almost half of our girls get married between the age of 15 and 19. So if you have that, that means if you're looking at your priorities and the issue of context, which Emmy touched on really well, is that not one size fits all. And we should all understand that adolescent is a very complex issue and never is to be siloed. As a young person, the young person, yes, might need their reproductive health, but as Nandita shared, you're looking at their economic development, but they're in contact with their communities that also function within structures. So as we organize our work, it's good to reflect and to understand all these factors that impact on the adolescent and also that help us as we move forward to plan better in our programming. So for a condition like I shared, like in Malawi, if you look at your priorities and you're saying, if you have young people that are pregnant at that age, how best can you reach them? So social norms and restrictions that are provided with providers is that it's easy for a young person to access that service if they are pregnant or have given birth, because now we have that shape of motherhood. And that means for planning, we should look at what is the best return on investment, but also long-term investment. So it is best to go where the young person is. And if we know that the young person is at the clinic, it makes sense that we corroborate and implement where the young person is, because then we're going to get greater gains. And we're also touching on the norms from within an acceptable phase, but also expanding that further. So that means if we strengthen full contraceptive counseling at that stage, even if an adolescent is pregnant, we are able to talk to them to delay their next pregnancy, to make sure they have a gap where they can reinvest in themselves, but also to make sure that these methods that Emmy shared, that if we offer full methods appropriate, one can actually be able to uptake these methods in their postpartum, either immediate or in the postpartum period. Meaning if we're thinking back, if that percentage of women of reproductive age, we're looking at the whole, is that we're not then just treating adolescents as a silo, but this is also working for all women of reproductive health, because as you increase the comprehensive counseling, even other women of reproductive health are getting the same. So we are driving and leveraging adolescents' reproductive health and improving it while strengthening the structures that exist. And another thing when we're looking at the how, I think it's to really realize that for a lot of countries, we talk a lot about improving adolescent health, and this HIP also helps to bring about, is to really look at our investment channels, but also financing channels. We can see that there's a lot of good work people are doing, but it's to say if we need to replicate them, where they're visible when they're implementing, and also is the issues that we're looking at the real need, really the real needs. How are we then using the data, as Michelle highlighted, how are we using the data that we have to make the best decisions for us? This might mean that per country, if we're looking at a country level national committee, is to be able to look at the data, but make sure the data speaks and we're able to visibly assess and adjust our programs. This means that we need to implement a learning aspect to our programming, so that if we're starting a new program that maybe we know it's based on high impact practices, but maybe has not quite been implemented that way, we might learn as we go, and to have the young people at the table, not, as I think Amy shared so well, not just as community mobilizers, but that they're doing the analysis, they're offering the feedback, they're collecting satisfaction and quality data, things that are usually missing, sometimes the gaps that when we need to make the service, but also allowing us to innovate as we go about, while keeping the visibility piece of what we're doing functioning. Because if we do that, that means if we're learning as we're going, we're able to capture the measurement and the outcomes. And this might come in handy when then we're presenting to say, this is the impact that we're tracking, and this is why we need to prioritize adolescent reproductive health within the main reproductive health and family planning line, but also looking at the budget implications. Because even if you have a good program, if you cannot support that financing, then we have a problem. Because when I talk about adolescents, we have to look at services that are affordable. That's why also looking at it in the system as a whole is good, because you are subsidizing those services for everybody, but also bringing the reach closer to young people. And when we talk about context and appropriate solutions, also just thinking back on the HIPS that was slightly touched on, which looks at digital health. It's great because young people have mobile phones and we can reach that with the knowledge, but it's good to step back with the context. So one of the things we're involved with was looking at developing a mobile health application for young people, but it was also for national, and then it has a component for adolescent health. But of course, first we asked ourselves is, what is the range of our network coverage? And who is going to zero rate your cost? Because that's a cost that you know the adolescents can't take. But what are also the privacy issue to consider? Maybe in some contexts, this might not have been an issue because either young people have their own phones and their plans are paid for, but in places where they share phones, you then ask yourself that, does the message come as a pull or push? How best do you balance that? And if maybe your adolescents are not as literate, would you then be able to send them more audio and then also triangulate this to services? Because at the end of the day, I think across everything is that the knowledge has to grow. While the knowledge grows, we're also looking at the services that young people can access. But a key thing to also think about when you're looking at the how is sustainability and long-term and collaboration. Because as we said, adolescents looking at everything has a lot of elements and it's complex. So everybody comes on the table with different expertise. For example, Amy shared about the practices that they do while Michelle is bringing the data. So it's also working with people on the ground that each brings the piece but makes our work better than if we work as silos. Because if we work within the normal system for the data that we have per country, as we're collecting that data for young people, we're also strengthening the reporting nationally for how people decide, because all the districts will move forward to the sub-level, to the national, that will make the decision. If we don't strengthen that at that sub-level, then we have a problem at the end because we're missing the gap. And when we talk about collaboration, also thinking, I think, beyond what the HIPs have shown us, that thinking beyond our normal classical partners. Private sector is a very interesting piece that has been tapped, but not very well tapped. We can all work better to work with our local companies to better support adolescent health. This might be in a way that is the program in their catchment area, or does it serve because the young people are going to be their biggest consumers and it serves in their purpose? But also, companies might reach where we might not because of the strategies of how they work. How can we leverage that and their corporate social responsibility to be able to push what we have as for family planning? And lastly, just to emphasize also that not one size fits all, and all this was touched upon by the previous speakers, is that not each adolescent is the same. Every adolescent is different, and also every adolescent is at different level to offer as some insights. So we need to really listen, but also not just listen, but be there on the table and make sure that when we're the how as we design, implement, but evaluate really fits within the real needs. Thank you.
Wonderful. Thank you, Arwani. That was an excellent summary and reflection on the presentations that we heard. We have come to time, so I don't think we will have time for questions. However, we will share the questions with our presenters who may be able to follow up with those of you who submitted your questions online. Thank you again for joining this webinar. Before we close, I just want to again highlight that the recording will be shared. You can also find it on the link that you see on your screen. And I would like to thank again our presenters, Michelle, Amy, and Warwani, for their excellent presentations and reflections. We've heard a lot about the importance of data and using data to help inform how we can incorporate various HIPs into our programming, but also recognizing the importance of context and that not one size fits all. Youth, just like others, are very diverse, and we really need to be thinking about context and innovative approaches to engaging more with young people. With that, I'd like to thank the IBP initiative, the HIP collaboration, and FP 2020. And for more information, please visit the websites on your screen. Thank you all again for joining us, and enjoy the rest of your day. Bye-bye.